My name is Mujdى, lecturer of cardiology, Mansoura University. Today we will talk about heart failure. We have first introduction, then pathophysiology, classification, etiology, diagnosis, and finally management. Heart failure is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or rejection of blood. So heart fails to act as a pump, and it is manifested by clinical cardinal symptoms like dyspnea and fatigue and exercise intolerance, and of course fluid retention in the form of pulmonary edema and peripheral edema. About the pathophysiology, the cardiac compensatory mechanism include first the tachycardia and myocardial hypertrophy, and finally ventricular dilatation according to Frank-Starling law. And then we have the hemostatic compensatory mechanism in the form of activation of the sympathetic nervous system as a first line in order to maintain the cardiac output. In the vascular system, that result in the vasoconstriction, which means that we have more afterload on the heart. In the kidneys, we have decreased renal perfusion and stimulation of renin-angiotensin release, and of course aldosterone release, which will lead to eventually sodium and water retention. And in the liver, stores of the venous volume causing ascites and hepatomegaly. And the counter-regulatory response which happens in heart failure leads to increased sodium release of antidiuretic hormone, and on the opposite side we have a release of the ANB, atrial natriuretic factor, and the PNB, beta natriuretic factor from the ventricles, which lead to sodium and water excretion, which thus prevents severe cardiac decompensation. Another neurohormonal response in the form of endothelin secretion, which is stimulated by ADH secretion and catecholamines and angiotensin II, and that lead to arterial vasoconstriction and the increase in cardiac contractility and myocardial hypertrophy. And we have another harmful counter-regulatory response in the form of release of pro-inflammatory cytokines like tumor necrosis factor from the cardiac myocytes in response to cardiac injury, and that lead to cardiac function depression, which eventually lead to cardiac hypertrophy and contractile dysfunction and myocyte cell death. All of these neurohormonal responses over time lead to systemic inflammatory response increase, which all of these factors results in cardiac wasting, muscle myopathy, and cardiac muscle fatigue. On the other side, we have increase in both ANB and PNB secretion. They are both released in response to increase in the atrial volume and the ventricular pressure. Both promote venous and arterial vasodilatation, which lead to reduction of preload and afterload, but prolonged heart failure lead to depletion of these beneficial factors. So the consequences of compensatory mechanism are ventricular dilatation in the form of enlargement of heart chambers, which lead to elevation of the left ventricular pressure. Initially effective adaptive mechanism, but this mechanism inadequate and lead to finally decrease of the cardiac output. And according to Frank-Starling law, initially increased venous return result in increase of the force of contraction, but later it increased the ventricular filling and the myocardial stretch, which lead eventually in ineffective contraction, and the hypertrophy which happen in muscle mass and cardiac wall thickness in response to cardiac dilatation lead to finally to heart muscle poor contractility and the increase in oxygen needs due to hypertrophy of cardiac muscle, and also a poor coronary artery circulation, which also lead to more vulnerability of the muscle to ventricular dysrhythmia and sudden cardiac death. Eventually, we have what we call the ventricular remodeling or cardiac remodeling, which refers to the change in the size, shape, structure, and the physiology of the heart after injury to the myocardium, either in the form of hypertrophy or cardiac dilatation. As a review of the heart failure pathophysiology, we have first the reduction of the cardiac output, which lead to activation of the sympathetic nervous system that lead to increase of the heart rate, and on the other side, a reduction of the renal blood flow, which lead to activation of the RAS system. Both lead to arterial and venous constriction and salt and water retention, and that lead to more remodeling and more stretching of the myocardium and ventricular hypertrophy, and finally ventricular dilatation, and more failure of the heart. End result, either we have a fluid overload, acute decompensation of the heart failure in the form of pulmonary edema, or chronic decompensation in the form of general fluid overload. The heart failure classification, we have the classic classification in the form of acute versus chronic heart failure, and the recent classification, which is systolic versus diastolic heart failure, or what we called heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction. And we have, of course, right-sided versus left-sided heart failure, and high output heart failure versus low output heart failure. This is the recent classification of heart failure, like I said, according to the most recent European guidelines, into heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Of course, we have the heart failure of reduced ejection fraction when we have ejection fraction less than 40, and heart failure with preserved ejection fraction when we have ejection fraction more than 50. And we have what we call a mid-range heart failure when we have ejection fraction of 40 to 50, and that have both types of heart failure. It may assume that it's diastolic or systolic heart failure. And this diagram illustrates both types of heart failure. The systolic or reduced ejection fraction type, when we have a weakened heart muscle that cannot squeeze the blood and eventually lead to less blood pumped out of the ventricles. And the other type, which is diastolic heart failure or heart failure with preserved ejection fraction, when we have a stiff heart muscles which cannot relax normally, and that lead to also less blood filling the ventricles. As regards the etiology of the heart failure, we have the ischemic heart disease, which lead to myocardial scar, myocardial stunning, epicardial coronary artery disease, abnormal coronary microcirculation, and endothelial dysfunction. We have toxic myocarditis, which lead to heart failure caused by radiation, medications like cytotoxic drugs like anthracycline, immunosuppressive drugs like interferons, monoclonal antibodies such as trastuzumab, some antiarrhythmic and some antidepressant drugs, and nonsteroidals. And we have heavy metals like copper, iron, and lead, and some substance abuse like alcohol, cocaine, amphetamine, and steroids. And heart failure sometimes caused by immune-mediated and inflammatory damage, either related to infection by bacteria, viruses, and parasites, from which the most known parasite is Chagas disease. And sometimes it's not related to infection, like giant cell myocarditis, and autoimmune disease like Graves' disease, rheumatoid arthritis, and connective tissue disorders, mainly systemic lupus erythematosus. And sometimes hypersensitivity like the eosinophilic myocarditis. And heart failure can be caused by infiltration, either related to malignancy by direct infiltration, or not related to malignancy like the amyloidosis and sarcoidosis, and glycogen storage disease. And we have some metabolic abnormalities, either hormonal or nutritional, which lead to heart failure, hormonal like thyroid disorders, parathyroid disorders, acromegaly, hypercortisolemia, Crohn's disease, diabetes, pheochromocytoma, and nutritional disorders like deficiency in thiamine, L-carnitine, selenium, iron, calcium, and sometimes complex malnutrition like the malignancy, AIDS, and anorexia nervosa. We have some genetic abnormalities like the diverse form in the form of hypertrophic cardiomyopathy, idiopathic cardiomyopathy, non-compaction, arrhythmogenic right ventricular dysplasia, and restrictive cardiomyopathies. Other etiology of heart failure like the abnormal loading conditions, including hypertension, and valvular and myocardial destruction, like either acquired by mitral aortic tricuspid and pulmonary valve disease, or congenital defect in the atrial and ventricular defect. And we have pericardial disease like congestive pericarditis and pericardial effusion, or endomyocardial, either the endomyocardial fibrosis or endocardial fibroelastosis. We have high output state, like we said, high output heart failure in the form of severe anemia, sepsis, cytotoxicosis, Paget disease, pregnancy, and AV fistula. We have a volume overload condition like what happens in renal failure and iatrogenic fluid overload. And we have, lastly, heart failure caused by arrhythmia, either tachyarrhythmia in the form of atrial or ventricular arrhythmia, or bradyarrhythmia like the sinus node dysfunction and conduction disorders. For the diagnosis of heart failure, we have history, clinical examination, risk factors, precipitating factors, and investigation. History, the cardinal symptoms is dyspnea on exertion, or what's called exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, edema, and fatigue. We have other symptoms like cough with expectoration, altered sensorium for the CNS in the advanced cases with confusion and impairment of memory, and in mild cases headache and insomnia due to low cardiac output state. We have the GIT symptoms in the form of anorexia, nausea, vomiting, pain in the abdomen and abdominal fullness due to ascites, and we have genitourinary symptoms in the form of nocturia. Classification of dyspnea, we have the famous New York Heart Association classification of dyspnea, with class 1 dyspnea, which is dyspnea more than ordinary activity, whereas we have no limitation of physical activity. Class 2, it means dyspnea on ordinary activity, and we have slight limitation of our physical activity. Class 3, we have dyspnea on less than ordinary activity, and we have here marked limitation of our physical activity. And class 4 is dyspnea at rest, where that means the patient cannot carry on any physical activity without discomfort. And for our differential diagnosis for dyspnea, we have another form of disorders which lead to dyspnea, like asthma or COPD exacerbation, pulmonary embolism, pneumonia, acute coronary syndrome, and anaphylaxis. Factors for heart failure include male gender, elderly, hypertension, diabetes, valvular heart disease, and obesity. Precipitating factors for acute heart failure in a patient with chronic heart failure, like non-adherence to treatment or excess salt or fluid intake, medication and non-adherence and non-compliance, renal failure, especially in patients with missed dialysis, substance abuse like cocaine and ethanol, poorly controlled hypertension or diabetes, and maybe sometimes recent addition of some drugs like calcium channel or beta blockers, initiation of salt-retaining drugs like non-steroidals or steroids or thiazolidines, or new antiarrhythmic agents, and sometimes inappropriate therapy reduction. As regards the general physical examination for the heart failure, in mild and moderate cases, sometimes the patient shows no distress, except when he lies flat for more than a few minutes. And in severe cases of heart failure, the patient has to sit upright and have a labored breathing, and usually he is unable to finish a sentence. Sometimes we have cardiac cachexia, cyanosis, edema, and jaundice. For the vital signs, we have usually sinus tachycardia, decreased pulse pressure, decreased systolic blood pressure, cold extremities, congested neck veins with giant V waves. Cardiac examination, we usually have cardiomegaly with hyperdynamic apex, and by auscultation we encounter S3 and sometimes murmur of mitral regurg or murmur of other valvular disorders like aortic stenosis. Chest examination, we sometimes encounter bilateral fine basal crepitation in decompensated heart failure, and sometimes signs of pleural effusion with diminished air entry on both lungs or either the right or left lung. For the abdominal examination, we usually have tender pulsatile hepatomegaly and sometimes ascites in severe cases, and usually peripheral edema. To the investigations for heart failure, we have to do chest X-ray, ECG, cardiac biomarkers, echocardiography, and sometimes routine lab tests for the diagnosis of the cause and for prognosis. Chest X-ray, we usually have pulmonary venous congestion, cardiomegaly in 80% of cases, and interstitial edema. It's most specific for the final diagnosis of acute heart failure, but the absence of these signs doesn't rule it out. This is a chest X-ray of heart failure. We have a cardiomegaly, and we have upper zone vessel enlargement, which is a sign of pulmonary venous hypertension, curly P-line, which is a sign of interstitial edema, airspace shadowing due to alveolar edema, which occur acutely in bat-wing appearance in acute pulmonary edema and acute heart failure, and we have a blunt costophrenic angle due to pleural effusion. ECG is not useful for diagnosis of heart failure, but it may show early recognition of arrhythmia like atrial fibrillation, and sometimes it shows signs of ischemia or myocardial injury as a cause of the heart failure. ECG, we have an atrial fibrillation with irregular rhythm and no B waves and variable ventricular rate. And for the routine lab investigation, we have to do complete blood count to evaluate the anemia as a cause of heart failure and the basic metabolic panel like the electrolytes and the renal function test. We have two cardiac biomarkers which are specific for heart failure, and they are done when the cause of dyspnea is still unclear after the standard evaluation. And actually, these tests will detect ongoing myocyte injury, which may be clinically silent. We have the PNP, beta-natriuretic peptide, with most sensitive when we have the cut point over 500 picogram per milliliter. That means we have patient with heart failure. And we have the N-terminal proPNP, which is most sensitive when it is above 450 picogram per milliliter if the age is less than 50 years old, and above 900 picogram per milliliter if the age is 50 to 75 years old. Of course, as a basic investigation for heart failure, we have to do an echocardiography, which helps in assessment of cardiac structure, chambers, valves, pericardium, and great vessels, and define the type of heart failure and the possible pathology, and of course determine the left ventricular ejection fraction. This picture shows a normal heart in an echocardiographic view, which shows a normal left ventricle and aorta and left atrium and normal right ventricle. These two pictures show two different types of heart failure. The left picture shows the dilated heart and dilated left ventricle with stenotic aortic valve, and the picture on the right side shows another type of heart failure due to what we call the hypertrophic cardiomyopathy, which show enlarged and thickened myocardium in the left ventricle. Another example for the dilated cardiomyopathy as a cause of heart failure, this picture shows severely dilated left ventricle. Finally, for the diagnosis of heart failure, we have this algorithm. If we have our patient with these following criteria, either by clinical history, he has history of coronary disease, hypertension, exposure to drugs and radiation, use of diuretics, the patient have orthopnea or BND, or by physical examination, he has RALS, bilateral ankle edema, heart murmur, or abnormal apex beat, or any ECG abnormality. If all of these criteria are absent, we have no heart failure, and we have to consider another diagnosis. If we have more than one criteria, we have to do natriuretic peptide for the patient, and we have confirmation by natriuretic peptide, we have to do an echocardiography. And if we have no abnormal natriuretic peptides, the heart failure is unlikely, and we have to consider another diagnosis. And after we do an echocardiography, we have to confirm the heart failure by echo based on all the available data. Then we determine the etiology and start the treatment. Management of heart failure, the therapeutic algorithm is first by relieving by the congestion by diuretics, and then we start the management with ACE inhibitor and beta blocker as a cornerstone of heart failure, and we have to uptitrate both ACE inhibitor and beta blockers to the maximum tolerated dose. And if the patient is still symptomatic and the ejection fraction is less than 35, we add mineralocorticoid receptor antagonist. And then if the patient is still symptomatic, we then add either, if the patient able to tolerate ACE inhibitor or ARP, we remove or exchange the ACE inhibitor or ARP by what we call the ARNI, the angiotensin receptor neprilysin inhibitor, the new drug for treatment of heart failure. And if the patient is sinus rhythm and the QRS duration is more than 130 milliseconds, we have to evaluate the patient for the need for what we called the CRT, cardiac resynchronization therapy, and we may add the drug ivabradine if the patient still have heart rate more than 70 beats per minute. As a conclusion, we use the following drugs: ACE inhibitor, beta blockers, MRA, mineralocorticoid receptor antagonist, ivabradine, and we may use the new drug ARNI if the patient has or cannot tolerate ACE or ARP. And if we have still symptoms after all of these drugs, we may consider digoxin or hydralazine isonitrate for the patient. And as an eventual therapy, we may have what we call the left ventricular assisted device or heart transplantation. Thank you.